Thank you, sir. So, I'm going to be speaking on, as mentioned, diabetes care, type 1 diabetes care in India. So, I'll cover what is the type of care these vulnerable children and adolescents require, what is presently being done, and what is the way forward. So, I begin with a sobering statement that we have the world's highest number of children and adolescents suffering from type 1 diabetes. But if we look at the hard data, adults with diabetes, 74.2 million. Children and adolescents, mostly with type 1 diabetes, 0.23 million. We are a small number. We have about 24,000 cases per year. So, presence of this huge pandemic of type 2 diabetes, problems faced by children and adolescents with type 1 diabetes are often overlooked. Are there problems in proportion to their size? No. There are several daunting challenges in care of children and adolescents with type 1 diabetes, not the least of which is limited resources, limited expertise, limited infrastructure, limited facilities for care of especially long-term care of children with type 1 diabetes. There are geographic and socio-economic disparities. The management is complex, way more complex than managing type 2 diabetes. There are so many daily tasks, SMBGs, maintaining a record, analyzing that record, storing insulin, administering insulin, and not to mention the dietary management. God help you if you also have celiac disease along with type 1 diabetes, the dietary management becomes even more complex. So it becomes overwhelming for the child and the family, especially if you're illiterate. Cost of treatment, there is limited insurance, and the availability of resources is at best patchy in India. Free resources, I'll talk a little bit more about it. And finally, the impact of a chronic, often a complex disease to handle, the psychological impact not only on child and parents. So these are among the few challenges. This is just sharing one of the studies under the data under publication done at my institute, where we just looked at the financial burden on families of children with type 1 diabetes. So what we found, and mind you, these are the children, these are in who are coming to my hospital, which is a government hospital. We give them insulins free of cost, we give them syringes free of cost, and sometimes, depending on availability, we also give them glucometer and glucose sticks. So what we found, even with that being done, and of course consultation is free, the patients were spending on an average about 21,000 rupees or so every year, and bulk of this money was actually going on glucometer strips, as you can see here, and travel related issues. And so the family, especially who are poor, this would come to almost 1/4 of their monthly income was being spent on diabetes, even when they were coming to a government institute. Thankfully, the proportion was less for a relatively affluent population. So this is the kind of care a child with type 1 diabetes require. They require emergency management for complications like DKA and hypoglycemia. Mostly they require a long-term ambulatory care, and there are so many complications, so many components of that long-term ambulatory care. Our patients know, and the few people who provide care to them understand this fully. Because if you really want to give them a good quality of life, we need to be assessing their glycemic control and doing an individualized adjustment in insulin therapy. We need to be taking care of intercurrent sicknesses. We need to be screening for comorbidities and complications, addressing the psychosocial issues, and finally, diabetes education, and including introduction to new technology we've heard so much about in this conference. So, giving a comprehensive type 1 diabetes care is not within the purview of an individual. It requires a team effort led by an experienced pediatrician or a pediatric endocrinologist, ideally. And then, but you also require pediatric intensive care services, diabetes nurse educator, nutritionist, social worker, and other specialists depending on the complications that the poor child may land up in. And these children require a long-term structured follow-up. Thus, it's a team effort. A word about diabetes education in context of type 1 diabetes. There are so many things we need to tell our children and their families, beginning with even telling the family type 1 diabetes is not type 2 diabetes. No, your child will not respond to oral hypoglycemic drugs. Your child has to go on insulins. There is no alternative. For them, even to accept that itself is education. So telling them about the disease, telling them then everything about insulin, about SMBG, about diet, about exercise. There are so many things which need to be told even before a child is, ready to be let loose on insulin. And then so much on the follow-up. Growing with diabetes, school with diabetes, exercise with diabetes, and so on. Role of multiple people. And this is an integral part of type 1 diabetes management. And it's well recognized that if we give them just medical treatment, give them insulin, and that's it, without comprehensive self management education, this is unethical. This is inadequate care and this is unethical. We cannot do it. So we need to, absolutely need to focus on education. This will not only lead to improved quality of life, this will also ultimately lead to building a improved proficiency in self management, which is what we ultimately want the patient to do. But what is the current status in India? Let's see. So, medical graduates are ill equipped to provide comprehensive diabetes care. We hardly teach type 1 diabetes in an undergraduate curriculum. In fact, many pediatricians lack experience in providing optimum long term ambulatory control. There are very few pediatric endocrinologists. Adult endocrinologists are also limited, but thankfully not as limited as pediatric endocrinologists. But they do have relatively less experience in handling, especially younger children. I mean, if you're talking about a 2-year-old child or a 5-year-old child, it is difficult. You can't really expect an adult endocrinologist unless the handful of amongst those who are actually looking after children, because children have unique needs. So, optimum care right now is currently centered only in big cities, maybe in some medical colleges and associated hospitals and private hospitals. Unfortunately, in private hospitals, the costs tend to be high and not within the reach of everyone. And remember, it is not a one-day situation. It goes on. It is a disease that will remain with the child. So, situation is improving, but way less than what we need. So we now have DM pediatric endocrinology courses. Currently, 3 centers in the country are giving DM pediatric endocrinology. Still not a recognized specialty by NMC. Rather, there are fellowships in ped endo, and increasingly, our adult endos are comfortable with treating the older children with type 1 diabetes. So, what are the facilities available? So, this was about expertise. What about the facilities? Let's talk about some of the insurance scheme. The central government health scheme gives insulins and gives syringes. So we give, though it's in vial form, regular insulin and glargine. However, there is no formal policy on glucose strips and glucometer, neither about lancing devices and CGMs. So these are not routinely reimbursed. These are, so some people may push their way through, get them reimbursed, but there is really no policy on it, and these are not usually reimbursed. Likewise, there is no formal policy in ESI or railways. Insulins are available. Other CGMS device, even pump reimbursement is done on case-to-case basis. One significant advancement in this field has been guidelines for insulin pump provision established by CGHS in year 2023. And that is when some people like me started prescribing insulin pump to some of our patients. So the ministry formulated a group, and these guidelines were formulated for insulin pump provision in patients with type 1 diabetes. So there are elaborate guidelines. So what we hear in this meeting is give it to them, give it to the children when they are, are diagnosed. Right now, the patients who are eligible are those who have type 1 diabetes for more than 2 years, linked to a center that is experienced in giving care with a poor glycemic control and recurrent hypoglycemias. And this approval is given on a case-to-case basis, which is reviewed by a committee, and it's given only for 1 year at a time. There is a one-time cost that is given, which for a basic version of insulin pump is 2 lakh and sensor augmented pump at rupees 3 lakh. Just to say the pump we have been hearing about, the Minimeds 780G, the latest pump, is actually now costing 6 lakh rupees. So we are really, CGHS is really lagging behind on this aspect. And similarly, the consumables that are given, the CGHS is just giving about 5,000 rupees per month, which is just okay for meeting the requirement for a basic pump. It does not meet the requirements of other pumps. If we are looking at, say, 780G, the requirement is at least 12,000 rupees per month. So it is lagging behind, but yeah, something is being given. Then other government organizations and several states have started their own initiatives. Many of them are giving insulin, Many of them have also started having some kind of a policy for pumps, but it's variable and patchy. So ICMR also has done its bit. There is a youth onset diabetes registry that ICMR has started. It's not an overall encompassing registry in the sense that it is a clinic-based registry. So the numbers that are being reported in this registry cannot be claimed to be the actual number of type 1 diabetics in the country. Rather, it's likely to be underreported. But at least this registry is there since phase 1 commenced in year 2006, and ICMR has also come up with guidelines for managing type 1 diabetes. There are increasingly the Central Board for Secondary Education has come up for facilities for children in their school and for their exams, and various organizations have come up. So, Indian Society of Pediatric and Adolescent Endocrinology has developed clinical practice guidelines, and there are several diabetes education courses which are there on the website of ISPE, the Indian Society of Pediatric and Adolescent Endocrinology. Like Ideal is a course for diabetes nurse educators, Best for caregivers of children with diabetes, Ideas for diabetes education and awareness in schools. And for this, ISPE was also given an award for their innovative innovations in diabetes care. And if you go to the ISPE website, there are several resources for the caregivers, for schools, and for the physicians giving care. Apart from ISPE, many individual institutes and individuals have made their own contributions based on their own interests. So there are guidelines which are available. At my own institute, we've developed a proper clinic record book for children with diabetes. We have a structured education program, and we have developed patient care resources like what to do in case of sickness, what to do in case their blood sugar levels are in hyper range, and so on. And we keep holding diabetes education programs on a regular basis. So this is the kind of care these children require. But it's all insulin individual based interest and program persistence based. Then there are pharmaceutical companies, and here I must talk about CDIC, Changing Diabetes in Children program, which is providing insulin along with other measures to children in India and many other countries as well. And there are initiatives by NGOs. We have Mr. Anil here from Yogyan Foundation supporting children in and around Delhi, Type 1 Diabetes Foundation of India, another NGO. So they are doing their own bit to help these children. And this is something worth mentioning. This was a pilot study where for the first time, this is Sujay Ghosh group, when they really saw how type 1 diabetes care can be delivered in the community. They showed it in 5 districts of West Bengal, and they built upon the national program for NCD in adults. Piggybacking on that, they showed how the same system for NCD provision in adults can be used to provide care to children with type 1 diabetes. And that pilot program and experience of rest of us is right now being used to develop a Ministry of Health and Family Welfare guidance document, of which I am happy to be part, for program managers and service providers for NCD in children. So this NCD in children guideline, I'm not speaking more about it because it is still in draft stage. So I can't talk more about it. But if this includes provision of care for patients with type 1 diabetes at a community level, and I think this is a significant step forward for our country. So in a nutshell, I would like to say, as of now, there is no formal policy or system in place in our country for providing holistic care for children with type 1 diabetes, and that's the need of the time. We do not even know the exact numbers because Young Diabetes Registry is not sensitive enough to pick up all cases. We need to have a more robust registry. The facilities and expertise for providing long-term comprehensive care are inadequate and predominantly urban-centric. Very, very few people who can really give a long-term care. Government support is patchy and varies among individual states. Isolated efforts are in place by individual institutes, scientific organizations, NGOs, and pharmaceutical companies, which cannot really meet our requirement. So there is an urgent need for providing comprehensive type 1D care at the community level. At least we need to give free continuous supply of insulin, injecting devices, periodic monitoring of glycemic control, and responsive adjustment in insulin level and in insulin dose, and finally complication screening. This is the least that is needed. And we do need a policy on NCD management, which is in making. Hopefully, this will be the way forward. So, friends, I would end on a hopeful note. We know what needs to be done, how it needs to be done. We just have to persist with our efforts. We will get there. Thank you.